Multiple sclerosis management. The treatment in multiple sclerosis is focused at reducing the frequency and the duration of relapses. There is no cure. Acute relapse treatment would be high-dose steroids, oral or IV methylprednisolone may be given for 5 days to shorten the length of an acute relapse. It should be noted that steroids shorten the duration of a relapse and do not alter the degree of recovery. Whether a patient returns to baseline function, that is not altered by steroids. Then we have disease-modifying drugs. Beta interferon has been shown to reduce the relapse rate by up to 30%. Criteria do exist. Certain criteria have to be met before it is used, as the reduction in relapse is as up as 30%. That means it does not benefit all the patients. Relapsing remitting disease plus 2 episodes in past 2 years plus able to walk 100 meters. These criteria are highly technical, so you need to pay attention. There's the 2 episodes over the 2 years, so now you have the dispersion in time is quite allocated, plus a functional status of being able to walk 100 meters unaided. This is relapsing remitting disease. If it's a secondary progressive disease, the criteria is different. It would be 2 relapses in past 2 years, so the same time allocation, but able to walk 10 meters, whether aided or not. Now, beta interferon reduces number of relapses in MRI changes. However, it doesn't reduce the overall disability. And this disability point is a common exam question. There are certainly other things that we can use to manage multiple sclerosis. Other drugs used in the management of multiple sclerosis include glatiramer acetate. Glatiramer acetate, okay? Glatiramer acetate, that would be T-I-R-A-M-E-R acetate. It's an immunomodulating drug that acts as an immune decoy, all right? And that's all you need to know. Should you need further information, you go ahead and see what does it mean, immune decoy. It simply means that the autoantibodies will be used up by the glatiramer acetate instead of attacking the target myelin. Natalizumab. Natalia is a very nice lady, and so she's helping us defeat multiple sclerosis. Natalizumab is a recombinant monoclonal antibody that antagonizes the alpha-4 beta-1 integrin found on the surface of leukocytes, thus inhibiting migration of leukocytes across endothelium across the blood-brain barrier. So it inhibits recruitment and epistaxis and chemotaxis. And then we have the famous fingolimod, which is a sphingosine 1-phosphate receptor modulator. And this one, most people have heard of, and most people are choosing correctly on examination. Many people don't know how it works. It's a sphingosine 1-phosphate receptor modulator. What it does, it prevents lymphocytes from leaving lymph nodes. An oral formulation is indeed available. Now, there are some specific problems. Look, for fatigue, once other problems, example, anemia, thyroid, or depression, and remember, remember that one autoimmune condition can lead to the other. So fatigue, once you rule out anemia, thyroid, depression, once all of these have been excluded, NICE recommended a trial of amantadine. Amantadine. And you do remember that we use amantadine in in Alzheimer's disease, and that it's also an antiviral medication. It's got 2 very different mechanisms of action. Okay, and so why do we use amantadine, and when do we use it usually? Amantadine is usually an anti-Parkinsonian medication, not anti-Alzheimer's, anti-Parkinsonian medication. So it helps you move better, right? Well, anything that is anti-Parkinsonian means that it promotes the function of dopamine. Amantadine is a 1-amantalamine organic compound, and what it does We use it for influenza, we use it for Parkinson's, we use it for fatigue and multiple sclerosis, and those are the only three things that we know about. And it's an antagonist of the NMDA receptor, type glutamate receptor, and increases dopamine release. NMDA is indeed a stimulatory receptor, but through the basal ganglia of inhibition of the inhibition of the inhibition and stimulation of that original inhibition is some crazy circuitry, so it really doesn't matter. Just know that it makes you feel better when you're Parkinsonian or you're having fatigue with multiple sclerosis. Amantadine. So now we have Amanda and we have Natalia, and they're both very nice ladies that are helping us with multiple sclerosis. And then we have spasticity, and for spasticity, you want to use baclofen, and you want to use gabapentin as the first line. Baclofen will act on the spasticity. It treats muscle spasticity by hyperpolarizing the primary afferent fiber terminals in the spinal arc, in the spinal reflex arc. Okay, so it's a muscle relaxant, more or less. Whereas gabapentin will work on neuropathic pain, and so it will reduce the pain that you get from the muscle spasticity, because too much muscle spasm will cause too much pain. Other options include mindfulness training and cognitive behavioral therapy. That's for fatigue, sorry, not for spasticity. It would be completely senseless to get someone spastic and tell them, hey, be mindful, have some cognitive behavioral therapy. That's just insane. Okay, for spasticity, you can do something else. Don't blame it on them and go tell them, hey, be mindful and stuff like that. Take them and do some physiotherapy. It is rather important. Here is something you might like. Cannabis might work. And Botox and cannabis are currently undergoing evaluation for the purposes of spasticity treatment. What about bladder dysfunction? Now, the bladder may become dysfunctional in multiple sclerosis. That dysfunction may take the form of urgency, incontinence, overflow, etc. Guidelines stress the importance of getting an ultrasound first to assess bladder emptying. And then you can use anticholinergics, because anticholinergics may actually worsen symptoms in some patients. Very, very important, because you want to know what type of bladder problem you have. And that was a discussion in a different section that we'll discuss later on in regards to bladder dysfunction. If significant residual volume is in the bladder, intermittent self-catheterization will help. If no significant residual volume is found in the bladder after ultrasonic assessment, then anticholinergics may help improve urinary frequency. And then finally, you have oscillopsia, that is, visual fields appear to oscillate. Remember, there is hemianopsia. Opsia means vision. Oscillopsia, vision is oscillating. Well, for that, also use gabapentin. Why and how, it really doesn't matter. It's something weird that happens only in multiple sclerosis and very few other things. So just remember it that way and answer it correctly on the exam. Thank you very much for attending this rather bizarre and short